speaking once again, and we'll be discussing about the revolution in management of heart failure. We knew that the role of SGLT2 inhibitor has been really very, it's like a miracle, panacea for all cardiac disorders, for the renal disorders. So it has been working everywhere, and in diabetes also, and it's like an automatic molecule. So if your blood sugar is high, it will decrease the blood sugar, but if you are non-diabetic or euglycemic, the blood sugar will not decrease, but it will keep on giving you the other benefits. So that's the unique molecule. We will be seeing that majority of the patients who are having reserved ejection fraction. We were discussing with Dr. Mangla just before we started this evening. There are a lot of patients who are, if you do their lung function test, they are normal. Do the echo, they have got normal ejection fraction, but still they are significantly breathless. So those are the groups where we call it is heart failure with reserved ejection fraction. So briefly we will discuss that as well. So the heart failure, as you would know, has got a worse prognosis than many cancers, and the survival is 50% of people would die within 3 to 5 years. So that's such a bad prognosis. So till now we were focusing only on heart failure with reduced ejection fraction, but now we know that the mid-range ejection fraction, the heart failure with reserved ejection fraction also maybe it may not sound as bad as reduced ejection fraction, but the prognosis is equally bad. So we will discuss about the proof of concept of SGLT2 inhibition for heart failure care beyond diabetes. So diabetes, whether the patient has diabetes or no diabetes, doesn't matter. We need to give the heart failure medication, and a diabetic drug which is SGLT2 inhibitor and Empagliflozin in particular has shown to improve the outcome. We'll also discuss about the clinical evidence in patients with chronic heart failure with reduced ejection fraction, mid-range ejection fraction, and reserved ejection fraction. I'll come back to you what is reserved ejection fraction, mid-range, and the low ejection fraction. And also the initiation in stabilized acute heart failure patient with an early outcome, and we'll sum up the whole thing. So if you look at the empagliflozin, that induces the modest glycemia in people without diabetes. So a lot of people were feeling that if we give SGLT2 inhibitor empagliflozin in patients who have got no diabetes, they'll go into hypoglycemic episodes. We had, I had one patient where she was given in prescription Dexona, and she continued to take Diabil. By mistake, the chemist had given, and she went into severe hypoglycemia and had hypoglycemic encephalopathy and had long time to recover from that. But these newer generation of anti-diabetic agents are automatic. So if you do not have diabetes, they will not lower the sugar in the same range or not at all. So that is why I call them as a very automatic drug. So if you see this slide, glycosemia within 24 hours after a single dose, you see comparison of empagliflozin 10 milligrams and 25 milligrams. You can see if the person has no diabetes, the urinary glucose excretion is significantly lesser, 40 to 50 milligrams grams of glucose loss occurs in 24 hours in people without type 2 diabetes, whereas there is a modest glycemia does not predispose to hypoglycemic episodes. So they will tolerate this molecule, and if the patient who has got diabetes, you can see in the right bar that empagliflozin 10 milligram would cause almost 64 grams of glucose loss, and 25 milligrams nearly 80 gram of glucose loss. So in people without diabetes, empagliflozin does not significantly affect the fasting and postprandial plasma glucose level. So this is the concept that we found in trials after trials, that this is a molecule which does wonders in patients with coronary artery disease, patients with heart failure, patients with chronic kidney disease. So then the thought came that can it be utilized in patients who are non-diabetic? And the answer, proof of the concept came that yes, it can be used in patients who do not have diabetes, because it's automatically glucose controlling agent. So if you see the effects of SGLT2 inhibitors on the pathophysiology of heart failure, there is a preload reduction. So in free water clearance would be increased, in stress blood volume will be decreased, the pulmonary vascular pressure will go down, intraglobal pressure will go down. So in turn they cause cardiac benefit and the renal benefit also. But it's a wonderful drug for the heart as well. If you see the effect on myocardium, there is an increase in metabolic efficiency, increase in diastolic relaxation, there is increase in oxygen demand supply balance, and left ventricular hypertrophy goes down significantly, and left ventricular remodeling and fibrosis. So at the cellular level also there is a lot of benefit, and in turn it would lead to improved cardiac structure and function. And then, as we know that heart, if it has to work against a high pressure, we call it afterload, then it will fatigue. So people who are hypertensive, those who have got high peripheral vascular resistance, there the heart will fail early. So this is a molecule which increases the endothelial function, improves, decrease in vascular stiffness. It also leads to neurohormonal stimulation decrease, which in turn leads to peripheral vasodilatation, and autoimmune balance also improves significantly. So empagliflozin improves the cardiac structure and function in patients with heart failure with reduced ejection fraction with or without diabetes. So that is the empatropism study. You can see the left ventricular and diastolic and systolic indices, they become significantly better when you compare to placebo, meaning thereby that it has got significant improvement in those segments as well. And empagliflozin improves the cardiac function in patients with HFEF without diabetes also. So till now we have been using it in diabetic patients alone. We had data, last year, end of the or early this year, about the benefit of empagliflozin in similar benefit in non-diabetic patient also, and intuitively we have been using it before these data came and before the approval came, and DCGI in India has given approval for uses in these segments as well. So if you look at the clinical evidence in these group of patients, so when we say that heart failure with reduced ejection fraction, it means that the ejection fraction is less than 40%, mid-range means 40 to 50%, and preserved means anyone who has heart pumping efficiency or ejection fraction which is more than 50% is the preserved ejection fraction. So if you look at the Emperor reduced study, that was a phase 3 randomized double-blind placebo-controlled trial where empagliflozin in this trial was used 10 milligrams compared to the placebo. And what do you see? You see a very remarkable data that cardiovascular death or hospitalization for the heart failure with empagliflozin versus placebo, there is a almost 25% relative risk reduction, and AAR ratio also 5.2%, and number needed to treat is just 19. So that's a huge benefit. So the bottom line is that patients who are non-diabetic, there also, if the heart failure is there, you can clearly give this molecule and reap the benefits. The risk reduction from mortality or worsening of heart failure from starts right from the date. You do not have to wait once you started this molecule. You don't have to wait beyond 3 months or 6 months to get the beneficial effect. At the 12th day, you start getting the graft separation, and it continues when you compare to placebo. Empagliflozin continues to separate from the graft, and the benefit, it means that it's happening to our patients. So if you look at the other hard endpoints, cardiovascular death, heart failure, hospitalization, remember any repeat hospitalization due to heart failure increase the mortality. It's just not another hospitalization, but it increases the mortality. And if you see the group where patient is a diabetic patient or non-diabetic patient, both would get significant benefit out of this molecule. So that is why it is so overwhelming. So empagliflozin does not worsen overall safety outcome in patients with heart failure with or without type 2 diabetes. So you do not have to really worry about that. If you started this molecule, patient will go into hypoglycemia or any other complication, ketoacidosis and all. It does not happen. The severe hypoglycemic events are same as 0.8 to 0.6%, same as the patient whether he is a diabetic or non-diabetic. So it means that we can safely give this molecule. And if you look at as I was saying, that this is something which is really revolutionary in kidney also. So end-stage kidney disease or sustained profound decrease in eGFR also significantly reduced. So if you look at the hazard ratio, that is 0.50. So it means again there is a huge benefit of this molecule and relative risk reduction of slowing down.
There's a lot of promotion in the back. Please keep silent so that we can listen to him.
Yeah, so please maintain the decorum, otherwise Dr. Chauhan will have to come on the diet.
Dr. Chauhan is
Where is Dr. Chauhan?
I think Dr. Chauhan was the source of this noise.
Where is he?
Anyway, so we'll start. So if you see the benefit in chronic kidney disease, again the progression to end stage renal disease is significantly delayed. So that's again a very, very important point, and that is why now the embracing this molecule by the nephrologists and the physicians at large has really increased. So now briefly about the Emperor Preserved study. What does it say? That if the ejection fraction is more than 40%, we did not include it into heart failure with reduced ejection fraction trial, but we presume that those heart patients whose ejection fraction is more than 40%, they would not have significant issues, but that is called heart failure with mid-range ejection fraction and heart failure with preserved ejection fraction. And there also in diabetic and non-diabetic patients, the empagliflozin 10 mg was utilized, and you can see the Emperor Preserved data that early and consistent benefit with empagliflozin observed by day 18 for time to cardiovascular death or hospitalization due to heart failure. So hospitalization due to heart failure is very, very important issue, because the patients who get hospitalized, their mortality significantly jumps, whether it is heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. So people feel that if the ejection fraction is normal, then the risk to life is less. That's not true. They are equally at a high risk of mortality. So that is why we should treat heart failure with preserved ejection fraction also with the same vigor and with the same enthusiasm and with the same intensity, so that we don't lose those patients. So if you see the Emperor Preserved results in patients with ejection fraction 41 to 49% and more than 50%, you can clearly see the cardiovascular death or hospitalization for the heart failure. When you compare the green bar, that is with the empagliflozin, compared to the placebo, which is the black bar, there is a significant benefit when mid-range heart failure, where the ejection fraction is 41 to 49%. You can see that number needed to treat is just 21, and the relative risk reduction is 29%. And when you look at the preserved ejection fraction, where the ejection fraction is more than 50%, you get significant benefit, not same as in the mid-range, but significant benefit where the number needed to treat is 42 and relative risk reduction is almost 17%. So cardiovascular death or hospitalization to the heart failure risk reduction by status of type 2 diabetes, age, chronic kidney disease, atrial fibrillation or no atrial fibrillation, there is a, you can see that the whether patient is diabetic or non-diabetic, benefit is almost similar. Again, when you see the safety outcome, so we were concerned that if the patient is non-diabetic, probably he will go in hypoglycemia. That's not true. The risk of ketoacidosis, hypoglycemia, and in patients whether they are diabetic or non-diabetic is almost similar. So empagliflozin represents first therapy with conclusively proven benefit in patients with heart failure with preserved ejection fraction, regardless of type 2 diabetes. So just to give you the perspective that in heart failure with reduced ejection fraction, we had so many molecules, as Dr. P K Gupta was saying in the beginning, that we can give SGLT2 inhibitor, we can give ARNI, we can give them MRA, mineralocorticoid antagonist, we can give them beta blocker. But in preserved ejection fraction, we did not have any molecule which will decrease the mortality and hospitalization except mineralocorticoid receptor antagonist. But now we have got this molecule which has shown not only to decrease the hospitalization, not only decrease the symptoms, but also decrease the mortality. So that's a very, very hard endpoint. So if you look at the empagliflozin, that lowers the risk of cardiovascular death or hospitalization due to heart failure in patients across the spectrum of heart failure, and that is the data from Emperor studies, and you can see that this is a summary of the whole event rate. In heart failure with reduced ejection fraction, no doubt, all the SGLT2 inhibitors are having huge success in that range. If you see, the relative risk reduction is 25%, number needed to treat is 19. But as the ejection fraction improves, the number needed to treat goes up. If it is mid-range ejection fraction, that is ejection fraction between 40 and 50%, the number needed to treat goes up to 21. But when you go to preserved ejection fraction, that is EF more than 50%, then relative risk reduction is 17% and number needed to treat is 42, but nonetheless the benefit is significantly there. And the background I had given that there was no molecule before this data came to have such a powerful impact on heart failure with reduced ejection fraction, and that is the reason why FDA approves treatment of wider range of patients with heart failure, and that is empagliflozin is indicated and is the class 1 indication for heart failure with preserved ejection fraction. So if you see the initiation of stabilized acute heart failure and early outcome, so a lot of time people feel that probably if the patient has newly diagnosed or early onset of acute heart failure, we should refrain from using SGLT2 inhibitor. That's not true. And this data is very, very loud and clear and from India, that is CSI registered from Kerala, that clearly shows that if you use cumulative mortality and all that during the follow-up, guideline directed medical therapy would clearly show that there is a clear benefit of early initiation also. And in the range of key reasons for deviation from guideline directed medical therapy is worsening kidney function, hyperkalemia and hypotension. So when you give the REV, when you give MRA antagonist and also, you fear that the kidney function will deteriorate, but this is a molecule where it does not happen. It will improve the kidney function. So in patients, the impulse study data clearly shows that in hospital initiation of empagliflozin in stable patients post acute heart failure results in good outcome. And if you see the data, there again the patients who are currently hospitalized for primary diagnosis for acute heart failure, if they are stabilized, and randomization was within 24 hours. And what you see in this stabilization criteria, all the following criteria must apply to the inclusion, where the patient has to have reasonable stable systolic blood pressure, there is no increase in IV diuretics and all. It means that the patient has stabilized within 24 hours in hospital, and then you can start this molecule. And what you see when you start this molecule, empagliflozin initiation at hospital discharge in stable heart failure patient, which is data from Impulse study, showed results in 36% greater likelihood of clinical benefits, meaning thereby that if you start early in these group of indicated patients, the benefit is going to be humongous. So if you look at the summary of adverse event, as I said, that the adverse events are not too many, and when you compare with the placebo, that is empagliflozin, which is the green bar, whereas placebo black bar, you can see there isn't much difference. It means that the overall tolerance of this molecule is significantly as good as a placebo. So there are a lot of studies with recent heart failure event rates, and all of these patients shows that in hospital treatment initiation varied from 11% till 100%, like in Impulse study and Pioneer HF data. And what you see that the empagliflozin program, Milestone, improving the cardiac outcomes, and we started the revolutionary data which came from EMPIRIC outcome in 2015, and now we are in 2020 and 22, where we see the data from IMPACT MI data, effect of hospitalization to heart failure or mortality in post-MI patients, high risk of heart failure. So this is again a trial which is we are part at max of this global trial as well. So if you see this summary, the why, how and when of using SGLT2 inhibitor in cardiovascular medicine. Why SGLT2 inhibition? Because it has proven benefits in heart failure across spectrum of LV ejection fraction, meaning thereby whatever the ejection fraction be, if the patient has heart failure, this is the molecule to look for. The early onset of cardiovascular risk reduction is there, so the graph separates as early by 12 days, so it means that you don't have to really wait for years together to get the good outcome. Lesser safety concerns are there, so it is like a placebo side effect, synergistic effect with other cardiovascular therapy, meaning thereby the pillars of heart failure treatment like SGLT2 inhibitors, ARNI, beta blocker, MRA antagonist, levodopa and all, it will go hand in hand with that, and the tolerance is good because it does not decrease the blood pressure, it does not cause any other significant side effects, so that is one of the reasons why it should be chosen as #1 drug. And how does it work? It has got a salutary effect on pathological pathway. Volume and pressure offloading is there, which is the prime culprit for heart failure patients. And the beneficial effect via cardiac axis, there is an improved cellular metabolism. And when to use it? as foundational therapy in heart failure regardless of LV ejection fraction, meaning thereby that you don't have to be Pandit of heart failure. If you see that the heart failure is there, means if the patient's NT-proBNP is significantly raised, you can blindly start it. You don't have to think whether the patient is diabetic or non-diabetic. If the heart failure is there, this is the molecule to look for. And in hospital discharge, you need to have a reason why this molecule has not been included. And sick day rule is that avoid use in acute severe medical illness, acute urinary tract infection, discontinue 3 days before planned surgery, avoid use in type 1 diabetes, counsel for good perineal hygiene, and monitor the risk of GTI so that we can use it. So it's not something where the patients who are at high risk of UTI and all, there it should be used. And in acute stressful situation, we should try and avoid it, especially if the patient is going for surgery. So I think on that note, I will end my talk, and thank you very much for your kind attention.
Sir, Dr. Chhabra, sir.
Dr. Viveka, thank you very much for giving us such a wonderful talk The question hour is open. Please be specific, small questions, and Dr. Chhabra will be speaking later on after the question hour is. Thank you. Please ask. Whosoever wants. Dr. Tulsi, please.
So, thank you, Dr. Viveka.
Dr. Chhabra is saying that the lecture was so good that there should not be any question.
Lots of questions. So,
Dr. Tulsi, I would like to share something. After the SGLT2 and the army, the cardiologists are so happy. They are treating diabetes. Even they don't require the endocrinologist, I think, or the diabetologist, or the physician. They are very happy with the army and the SGLT2, even in the heart failure. Okay. Dr. Tulsi.
So, let me start by saying that it was indeed a wonderful talk and always a pleasure to listen to you, Dr. Viveka. So, when I used to manage ICUs, late 70s and early 80s, Lasix and more Lasix.
Ejection.
And Ejection, and maybe some vasodilators as well. Invariably, they would come back. Some wouldn't come back because they were all dead. So, this has been a paradigm shift, the way you treat heart failure these days. A new era has come now with the 4 fantastic drugs. So, these drugs are not only disease-modifying drugs, they are prognosis-modifying drugs as well. So, Dr. Viveka, can you tell us how do you sequence these drugs, the 4 drugs? Would you probably first start with ARNI and then SGLT2 inhibitor and then probably beta blockers or then the MRI? Having said that, the editor-chief of JAC, Dr. Valentin Foster said, individualized treatment in every patient. What do you have to say, sir?
Yes, I think that's a brilliant question. So when it comes to preserved ejection fraction, we don't have much choices because if you see the benefits is only with 2 molecules, SGLT2 inhibitor, especially the Empagliflozin and the MRA antagonist. Even ARNI failed the significance level. So in their prioritization is not an issue, and most of the diastolic heart failure patients, the blood pressure is not an issue, so we straight away start both the medications. Coming to the mid-range and reduced ejection fraction, now there are 2 ways to go about. One is what we call slam bang technique, where you start all the medication in whatever patient tolerates and gradually build up the dose. You don't have to start one drug and wait for maximum dose to achieve and then start the next drug. So one is sequential starting, so you start with ARNI, you build it up gradually, give 2 weeks and then gradually increase the dose and then start the other molecule. But right now, the benefit accrued by different mechanism of action is more important, and that is why you should start in low dose all the molecules. Having said that, you are not so lucky. There are many patients who in class 3, class 4 where the blood pressure will not let you allow to start RD or beta blocker. But in that case, the SGLT2 inhibitor will be first drug of choice. But those patients where the blood pressure is adequate, those who have already been on ARBs or RD, then you can start with RD or beta blocker and then add a SGLT2 inhibitor at a later point in time. So the benefit, amount of benefit in mortality is again, if you see the later trial that in very late stage of heart failure, so there is a data of RD, that patient who was in class 4, there the benefit, significant benefit was not there with RD, only this, some numerical benefit, but not the statistically significant benefit. So we need to go by slam bang technique where we start all the molecules. So earlier you start, so the slogan is that start it early and build it on, and you will be surprised that most of the patients who were initially not tolerating the initiation dose, they are tolerating in 3 to 6 months time the maximum guideline directed doses which is approved.
So my second question would be, Dr. Viveka, regarding the diamond study. See, as we know, RAS inhibitors cause hyperkalemias, and adding a potassium binder, a newer potassium binder like Pathophysiology, you could probably continue with the RAS inhibitors till about 85% of the people will tolerate that. And above that, if you give SGLT2 inhibitor, the hyperkalemia indeed is reduced. Sir?
That's again another benefit of this molecule, that if you want to decrease the hyperkalemia and the increased tolerance of these drugs, because remember, if you give MRA antagonist and RNA together, then the risk of hyperkalemia can go up, though the individual studies do not suggest. So if you add this molecule, the risk of hyperkalemia goes down, and that is why it is we say that you go slam and start everything in one go.
My third question, Dr. Viveka, regarding the prompt heart failure trial, there is a therapeutic inertia, for the doctors. There is an inertia for the doctors to write these drugs. So we probably need to make them aware that these are the drugs, the 4-methoxy drugs to be given as fast, as quickly as possible, as soon as possible. So I'm talking about the prompt heart failure trial.
Yeah, so I think in the world where the medicine would be given by the healthcare system free of cost, there also the inertia, I think that's what you're talking about.
Yeah.
So inertia is it's like a self-defense medicine where the people feel that we should not be actively, contributing to the adverse outcome of the patient. So we need to educate, like, for the SGLT2 inhibitor, not many people do not understand. A lot of patients would come back with my prescription that my chemist said that, you written this medicine which is for diabetes, and I am not a diabetic, so why did you write this? So that kind of education. So historically, it is something where people would doubly confirm with the chemist, not with the doctor. So that's a problem. Yeah, so I think that's the problem. But you need to educate and persist, and then only they would feel that this has to be.
My last question, Dr. Viveka. The recently concluded American College of Cardiology conference just last month, reduction with statins as well as the PCSK9 inhibitors, there were no benefits seen with heart failure. So, what is
if you look at the statins and PCSK9, they are primarily meant to decrease the coronary event. So probably numbers, if the trial has got as big number as 100,000 patients, then probably it might show some reduction in heart failure. But with these 10-20,000 trials, it will not show significant reduction in heart failure. But yes, there was 23% reduction in coronary event, post-MI plaque regression and repeat myocardial infarction event was significantly lower in PCSK9 inhibitor. So I think they are not meant for acute heart failure reduction, and the very reason why they are there, they are for coronary artery disease management, not for the heart failure.
Large number of patients, over 19,000 patients, and published in European Journal. Thank you, sir.
Sir, excellent question, Dr. Tulsi sir, and wonderfully answered by Dr. Viveka sir. Sir, some questions for lesser mortals who do not understand trials and are just busy in their day-to-day practice. Sir, what I understood from your talk on use of SGLT2 inhibitors beyond ejection fraction is that SGLT2 inhibitors must be used across the spectrum, whether the ejection fraction is reduced, it is mildly reduced, it is moderately reduced, it is severely reduced, or it is not reduced at all.
Yeah,
Sir,
provided
is that the message for all the practicing physician friends?
with heart failure.
With heart failure. Now, so the question comes, you also mentioned about the use of SGLT2 inhibitors even in non-diabetics. So if I am a patient of hypertension who doesn't have diabetes, not even pre-diabetes, am I justified in using SGLT2 inhibitor in this patient if he has got, let us say, even the earliest indication of a heart failure, let us say diastolic heart failure?
Absolutely. So that's what we were saying, that early initiation of this SGLT2 inhibitor has shown that you can start as early as the first, so class 1 heart failure is there, if the echocardiography sign of diastolic heart failure is there, or if the NT-proBNP is significantly raised more than the cutoff value. So then we are justified, to start this in those patients, whether the patient is diabetic or non-diabetic. So you are absolutely right. But we should not start in all hypertensive patients unless they have got heart failure. So I think we just had Dr. Mathur was there and Dr. Mangla was asking that, how do you, and he said that we should elaborate on that who are the patient, how would you diagnose diastolic heart failure. So that's a little tricky because you need to have a good echocardiographer, so where the EA ratio, E prime and A ratio, that is the diastolic filling is disturbed, and there are 4 grades of that. The left ventricular end diastolic pressure has to be high, and more importantly, the biological, biochemical marker has to be high. So the NT-proBNP and BNP and all those marker has to be high. So if they are high, so the cutoff value is that at least 1.5 times the normal, then I think we are justified, and we are very right that these patients, so what happens that the diastolic heart failure happens that the left ventricular hypertrophy, left ventricular muscular mass that increases and the relaxation becomes weak. But when you give this, there is the LV mass regression is also there, which in turn translates into good compliance, and the heart failure becomes better. So in also those patients who have got what we call type 2 myocardial infarction, where the demand supply mismatch is there, it works as a anti-anginal also. So there are decreased risk of ischemia and with decreased angina and all those things. So there also they are justified in using. Yeah, and
Sir,
whether the patient is diabetic or non-diabetic. In same continuation as Dr. Chapra prompted me, that patients where diabetes is not getting controlled, the patient is slightly on the overweight side, the body mass index is higher. There it is a very good adjunct as a that gives you enough margin that the patient's blood pressure will be controlled if you add this as a modulator of the after load reduction. So this is something. So many a times you are struggling with multiple drugs, but when you add this within 12 days to 4 weeks and all, the blood pressure starts coming down.
Sir, you beautifully mentioned that you cannot use it in hypertensives across the spectrum. You have to establish that this patient has got heart failure with certain biochemical markers, NT-proBNP as you mentioned. Sir, but as I understand in diabetics, and we understand that diabetes is CAD equivalent, and it is well known now. Every diabetic, if you do an echo, there will be some sort of a diastolic dysfunction, sir, from your long experience. So, would you advise all of us and our physician friends to start using SGLT2 inhibitors in all the diabetics?
Yes, again, if you see we don't say that class 1, stage 1 diastolic dysfunction is disease state. It is just the age more than 30 years everyone would have that. So we need to doubly do the other test, which is called NT-proBNP, and if that is high, then only we should start, not in everybody.
Not in all the diabetics. Right. Sir, the talk was on use of SGLT2 inhibitors beyond ejection fraction. Now, the data that we have today, sir, I understand that there is an additional benefit of nearly, there is a relative risk reduction of 20% as, I mean, on an average, sir. Although if you read in between the lines, it can be 22%, 23%. So, do you recommend as a cardiologist, sir, as an eminent cardiologist, that we should start using SGLT2 inhibitors even in patients with preserved ejection fraction every time, if they have any evidence of diastolic heart failure?
Yeah, so I think that's what we have told, that diastolic heart failure with preserved ejection fraction, even if the patient falls in the group of mid-range, that is 40% to 50%, and beyond 50%, the number needed to treat may vary, but all of them are going to get benefited. So answer is loud and clear that yes, we should.
Sir, another last question, sir. Between systolic heart failure and diastolic heart failure, SGLT2 inhibitors are more effective in diastolic heart failure or in systolic heart failure?
So we've shown the data that in heart failure with reduced ejection fraction, the number needed to treat is least, so maximum benefit, and all the SGLT2 inhibitors have got significant benefit, not only in mortality but also hospitalization with heart failure. But as the ejection fraction improves, the total benefit accrued is lesser. But unlike RNI, where significant benefit was not there with RNI in preserved ejection fraction, SGLT2 inhibitor is a molecule where there was still significant benefit in mortality and the hospitalization of the heart failure. So it means that the benefit is more in more sicker and low ejection fraction patient, but the benefit is statistically significant benefit in preserved ejection fraction.
This is my last question, and it is an important question. Over the last 7-8 years that we've been learning SGLT2 inhibitors from eminent people like you, what we learned from EMPA was that empagliflozin, or Jardiance, what we call, reduces cardiac mortality, reduces overall mortality, it reduces MACE, and it has an impact on cardiovascular outcomes. Canagliflozin reduces MACE, reduces heart failure outcomes, but does not have a significant cardiovascular outcome reduction or a cardiac mortality reduction. Dapagliflozin does not reduce MACE and does nothing to the overall cardiac mortality, although it is wonderful, as good as the other SGLT2 inhibitors on heart failure. Sir, why is this difference? I mean, if you see, and if I want to use an SGLT2 inhibitor in a type 2 diabetic for my patient to reduce cardiovascular outcomes, there is only one drug left, and that is Empagliflozin. Can you explain this for very I mean, people?
Yes, I think you have rightly said that so the bottom line is that not all SGLT2 inhibitors are same, and the proven benefit which is there. So logistically it would look like that probably all are same, but it's not true. If you look at the end result outcome data, that is not, you can't compare that all of them are there. So if you see, we had a couple of days back delivered HF data also had come from dapagliflozin, and there the benefit was significantly there in preserved ejection fraction group as well. But as you rightly said that this is not, so if you look at the cardiovascular SGLT2 inhibitor, which I would call it, and we choose in that group empagliflozin as a number one molecule, because maximum data in high risk group, the heart failure with reduced ejection fraction, preserved ejection fraction, in all those groups it is there and we should be using. So, but if you see the heart failure with reduced ejection fraction or preserved ejection fraction, the data is pouring in with the other group also, and fluid overload situations like heart failure of any ejection fraction, all the SGLT2 inhibitors are beneficial. But when you go to the coronary benefit and the high risk cardiovascular patients, so in those situations empagliflozin is really good. Only molecule which comes closer in coronary artery disease with all the spectrum is the GLP-1 receptor analog, which is there. But I would say that I would still, if I have to put my money on one, I would put on empagliflozin.
Sir, my very last question to you, sir. Sir, often when we talk about heart failure patients, with an ejection fraction of less than 30%, you always write, I have seen on your prescriptions, total fluid intake 1.2 liters, and you write it beautifully. Your handwriting is so good, sir. At times I have to ask you, sir, it is 1.2 or 1.8. So 1.2 liters, and then you give SGLT2 inhibitors to this patient, sir, and it will cause increased volume of urine, polyuria. So if in a case of type 2 diabetes with heart failure, with reduced ejection fraction, if you start using Jardians, can you allow little more fluid to this patient or no?
So they are already plethoric. So the total, if you look at the fluid calculation like the nephrologists do, they are already overloaded with 7-8 liters extra. So in those situations, you don't really need to give extra fluid because the body will always, and remember this is a cellular mechanism whereby it will take more, intercellular fluid and then it will compensate automatically. So we don't tell them to drink. So a lot of patients who come to see the endocrinologist and then they come to us that, endocrinologist said that if you are taking SGLT2 inhibitor, you should be taking, a lot of water, and they said us to take at least 1.5 liters of extra fluid, whereas you are saying that no extra fluid, just 1.5 liters. So basically, these patients of heart failure, whether it is diastolic heart failure also, they are already plethoric, otherwise the NT-proBNP will not be high. So I would say that if the NT-proBNP is significantly high, there is no need to take extra fluid simply because you don't need it. It is already there in your body.
Sir, just for my knowledge,
Sir, thank you.
Just what is your cutoff EGFR for using an SGLT2 inhibitor?
So it has come down to 15 now.
Thank you. Dr. Johan, very nice questions, and all of us have.
May I just ask question?
Sir, can we discuss during the
Take only one minute.
please.
Last question.
What I am saying, if a patient of you see diastolic heart failure is admitted, then you give MRA, you give SGLT2. What is the role of diuretics in this patient when this patient is hospitalized? Number two, you see there are patients in which you feel that it could be diastolic heart failure, NT-proBNP is 500. In some patients the NT-proBNP is 5000. So what level of NT-proBNP you keep relevant?
Yes, I think NT-proBNP depends on the kit and all which you are using. So if anything which is like, if you look at the these trials, preserved, emperor preserved and all, there also the NT-proBNP was kept to be around 175. They had kept it up a little. So if it is 500, definitely it is high. Remember, NT-proBNP would also change according, based on the age of the patient. So age correction also has to be done. So if the age is 75 plus, then obviously the NT-proBNP even up to 750 would be acceptable. But you are right that these patients would have intuitively some amount of diastolic heart failure would be there, and role of diuretic is for symptom relief. So diuretic would not decrease the mortality and also what we were talking about. So diuretic is a very, very important component of treatment algorithm, where the patient's symptom will become better if you give the diuretic. But if you want a long-term decrease in mortality and hospitalization, then diuretic would not be the molecule to look at. So you are right that in acute decompensation, we need to give diuretic. If the patient is hospitalized, there is no other way. We need to give them diuretics. But later on maintenance therapy, we need to give at least SGLT2 inhibitor and MRI antagonist.
How early is the benefit?
Early benefit we
How early
showed
is symptomatically?
even at the 12 days, the graph separates. So it's very early.
In your admitted patients?
In admitted patients, so symptomatic benefit would, earliest benefit would be with the diuretics, but it will take, graph separation, which is a bigger thing, would happen
Sir,
at least in a week's
can
time.
we end the session
Yes, yes.
with questions answered very well by Dr. Viveka and very good questions. Let me thank all of us.